Hello everybody and welcome to our module on intestinal disorders. In this module we're going to go through a number of disorders that affect the small and large intestine. We'll start by discussing appendicitis. So appendicitis is acute inflammation of the appendix, and recall that the appendix is a blind-ended tube that's attached to the cecum. If you look at this picture on the screen, this is the cecum here at the beginning of the large intestine, and the appendix is this tube that comes off the cecum. It's often called the vermiform appendix. And the word vermiform means worm-like, and that's because it looks like a little worm attached to the cecum. Appendicitis occurs when the opening of the appendix into the cecum becomes obstructed. If it becomes obstructed, bacteria can accumulate behind that obstruction, and essentially you get a small abscess inside the appendix in the abdomen. There are a couple of things that can cause the outlet of the appendix to become obstructed. Fecalists can do this. These are hard fecal masses, and this is a common cause of appendicitis in adults. In children, it's more commonly lymphoid hyperplasia. There is lymphoid tissue at the outlet of the appendix into the cecum, and if that tissue becomes hyperplastic, for example, in reaction to a viral illness or some other stimulus, then that lymphoid tissue can obstruct the outlet of the appendix into the cecum, and this can lead to appendicitis. Patients with appendicitis can develop nonspecific symptoms like fever and nausea. However, they go on to develop a very characteristic abdominal pain that has several classic features that you need to know as a medical student. So the abdominal pain in appendicitis develops in the mid-epigastric region, usually around the umbilicus. Now this is usually not where the appendix is located in the abdomen, but the reason the pain starts here is because initially the inflamed appendix irritates the visceral peritoneum. The visceral peritoneum is innervated by the autonomic nervous system. This system is poorly localizing, so the pain will be generalized and mid-epigastric initially. As the appendicitis progresses, the parietal peritoneum will begin to become inflamed. This is innervated by the somatic nervous system, which is much more well-localizing. Therefore, the pain will move to the right lower quadrant, which is where the appendix sits. The classic location to find the pain once it's moved to the right lower quadrant is somewhere called McBurney's point. So if you draw a line from the iliac crest to the umbilicus and go 1/3 of the distance away from the iliac crest, that is McBurney's point. If you look at this picture at the bottom right side of the screen here, point number 2 is obviously the umbilicus. Point number 3 is the iliac crest. If you draw a line between those 2 points and go 1/3 of the distance from the iliac crest, that is point 1 here, and that is McBurney's point, and that is where the pain of appendicitis will localize to once the parietal peritoneum becomes inflamed and the symptoms move away from the initial epigastric region. You can diagnose appendicitis by history and exam alone. If the history and physical exam are strongly suggestive of appendicitis, patients are sometimes taken directly to the operating room. If the diagnosis is in doubt, or if you need more detail about the anatomy of the abdomen, you can perform a CT scan. Shown on the screen is a CAT scan of a patient with appendicitis. This is the inflamed appendix here. It's difficult to tell the appendix from other structures in the abdomen. You're unlikely to be asked to do this as a medical student. However, I just want you to know that you can see the inflamed appendix on CAT scan in many cases. And the definitive treatment is to go to the operating room for surgical removal of the appendix. Let me pause here and mention a term that you will hear often on your surgical rotations, and that term is called the acute abdomen. Patients are said to have an acute abdomen when they have the acute onset of abdominal pain associated with rebound tenderness. Rebound tenderness is tenderness you elicit on physical exam by pressing on the abdomen and then letting go. When you let go, the abdomen rebounds to its normal position, and if that causes exquisite pain for the patient, that patient is said to have rebound tenderness, and this reflects peritoneal inflammation. And there are several causes of abdominal peritoneal inflammation that are life-threatening, and that's why the acute abdomen is such an important diagnosis to make. Several of the causes of the acute abdomen require urgent surgical intervention. These include appendicitis, which we just talked about, also diverticulitis, which we'll talk about later, also ectopic pregnancy, and this is why beta-HCG testing is often done among women who present with an acute abdomen. If you fail to make the diagnosis of the acute abdomen and address it, it can progress, and there can be perforation of an abdominal viscus. A viscus is a structure in the abdomen. So for example, if the appendix bursts in appendicitis, this can lead to peritonitis, where the patient will develop a rigid abdomen and they can become septic and die. So the acute abdomen is often discussed on surgical rotations. It needs to be identified, and a decision needs to be made about surgical intervention so that we can avoid these life-threatening complications. Back to our discussion of intestinal disorders, let's move ahead and talk about diverticular disease. So a diverticulum in the intestines is a blind pouch or sac that extends out from the GI tract. If you look at this picture on the screen, you can see that there is a hole in the wall of the intestines. Sticking out from that hole is a blind pouch. That pouch is a diverticulum. It occurs when there's a breakdown in the muscular layer, and as a result there's protrusion of the mucosa and submucosa to form a pouch. This creates what's known as a false diverticulum. It's called false because it does not contain all the layers of the GI tract. I'll explain this more in just a minute. And this occurs at places where the vasa recta penetrate the muscularis of the colon. This creates a weakness in the muscular layer and creates an opportunity for the mucosa and submucosa to form a pouch. Recall that there are 3 layers to the lining of the GI tract: the mucosa, the submucosa, and finally the muscular layer. A true diverticulum is when all 3 layers form an outpouching or a diverticulum, and this is very rare. The most important time that this happens is in Meckel's diverticulum, which is a congenital anomaly of the intestines. And this is called a true diverticulum, and it's true because it contains all 3 layers. In an intestinal diverticulum, what happens is the muscular layer breaks down and forms a hole. As a result, the submucosa and the mucosa can penetrate through and form a blind-ended pouch. This is a diverticulum, but it's called a false diverticulum because it does not involve all 3 layers, and it results from a breakdown in the muscular layer, and the place where the muscular layer is weakest is where the vasa recta penetrate the muscular layer to supply blood, and that's where these diverticulum tend to occur. We call it diverticulosis when there are many diverticuli present in the GI tract, and this usually occurs in the sigmoid colon. This is a picture of what it can look like here. You can see that along the length of the sigmoid colon there are multiple sacs which are diverticuli protruding out from the wall of the intestine. That is called diverticulosis, and when patients are taken to the operating room for diverticular disease, you will often see a sigmoid colon that looks like this. And diverticulosis is caused by straining to pass stool. When you bear down to pass hard stool, you create wall stress that can pop the submucosa and mucosa through a weakening in the muscular layer and form these pouches. It's caused by chronic recurrent increased intra-abdominal pressure. And this usually occurs in people who don't eat enough fiber in their diet. They have a low fiber diet, they have hard stools, and they are chronically straining to pass the stools, and this leads to diverticulosis. Most patients with 1 or more diverticuli are asymptomatic and don't know they even have the problem. However, there are some complications of diverticular disease that can occur. The first one is lower GI bleeding, which is called hematochezia. The diverticulum can begin to bleed and cause blood in the stool. And then the second complication is called diverticulitis, and this is what happens when there is inflammation of the diverticulum or bacterial infection. So diverticulitis is inflammation of a diverticulum. It presents with fever and elevated white blood cell count from the inflammation. It classically presents as left lower quadrant pain. That's because usually diverticulitis occurs in the sigmoid colon. It is sometimes called left-sided appendicitis because it has rebound tenderness and other signs and symptoms of appendicitis. However, it occurs on the left side of the abdomen. Another characteristic finding is what's known as occult blood. Occult blood means blood that you can't see with your eye, but it is present and you can detect it if you do a special test. Shown on the screen here is a hemoccult test. You put a small smudge of stool on the test strip, and then you drop the solution on it. It will turn blue if there is blood hiding in the stool. So a positive test for occult blood is something that you commonly see in diverticulitis. You can make the diagnosis by CAT scan. You can see an inflamed diverticulum, and the treatment is usually antibiotics and sometimes surgery to remove the infected portion of the colon. Diverticulitis can progress into a number of more serious complications, and the first one is formation of an abscess. If bacteria become walled off inside a diverticulum, that will present as diverticulitis symptoms that do not improve after antibiotics because antibiotics cannot penetrate an abscess. This often requires surgical therapy. Diverticulitis can also progress to a bowel obstruction. The inflammation can narrow the intestinal lumen and obstruct the passage of air and feces and fluid. This will present as nausea, vomiting, abdominal distension, and potentially constipation. Another complication is a fistula. This is a connection with another structure in the abdomen. Most commonly it's the bladder. This is called a colovesical fistula. This will present with air in the urine. This is called pneumaturia, or fecal matter in the urine. This is called fecaluria. And these can both lead to infection and inflammation in the bladder and the urinary tract, and that will give symptoms of dysuria. And then finally, diverticulitis can progress to cause perforation. This will result in peritonitis, and the patient will develop diffuse abdominal pain with a rigid abdomen. Our next intestinal disorder is the presence of adhesions. These are bands of scar tissue in the peritoneal cavity. These are commonly formed after someone has had surgery. If you look at this picture on the screen here, this is an image taken with a laparoscope. The surgeon is peering into the abdomen, and you can see this adhesion connecting different structures inside the peritoneum. So for example, if someone has surgery, such as surgery to remove their appendix for appendicitis, or if women have C-sections, after the surgery they can be left with these adhesions. and they can cause different intestinal problems. One of the most common things they cause is a small bowel obstruction. They can also cause infertility in women because they can interfere with transport of the ovum. They can also cause chronic abdominal and pelvic pain as the intestines try to contract and they are resisted by the adhesions, and this leads to chronic pain. The treatment is to perform a surgery called a lysis of adhesions where you try to cut these up. This is problematic, of course, because the surgery to lyse the adhesions can lead to more adhesions. Intussusception is a telescoping of the intestine where the intestine folds into its own lumen. This is a picture of what it might look like on the screen here. You can see this proximal portion of intestine has folded into the more distal part. This folded part is called the intussuscepted portion of the bowel. This is a dangerous problem because the blood supply to the intestine can be compromised. This can cause necrosis and bleeding, and the patient will present with GI bleeding that is classically described as appearing like currant jelly. If you don't know what a currant is a type of plant. This is a picture of some currant on the screen here. And the GI bleeding that occurs in intussusception will be thick and red like currant jelly. This is a medical emergency and it's common in children, often less than 1 year old. It's very rare in adults. And it often occurs near the iliocecal junction. If you look at this picture on the right side of the screen here, this is where the ileum inserts into the cecum, and this is where intussusception often occurs in children. For step 1, it's very high yield to understand a concept related to the pathogenesis of intussusception called presence of a lead point. The idea here is that an underlying lesion of the bowel often triggers intussusception. The intestine becomes trapped by an underlying lesion, and then peristalsis drags the intestine to form intussusception. If we go back to this picture, the idea of a lead point is that some lesion pinches the bowel, and then peristalsis causes the bowel to intussuscept and telescope in on itself. Potential lead points are Meckel's diverticulum in children. This can cause intussusception. Lymphoid hyperplasia is a classic cause of intussusception. There are Peyer's patches which can become enlarged in viral gastroenteritis, and that can trigger intussusception. This is probably the reason that there is a strong association between enteric adenovirus infection and the development of intussusception in children. This is a very high yield association to remember for step 1. And then finally, in adults where intussusception is less common, tumors are often the lead point. Moving on, let's talk about intestinal volvulus. This is when there is a twisting of the bowel around the mesentery. This is a picture on the screen of what it might look like at surgery. You can see that a portion of the bowel has twisted around the mesentery and is large and dilated. The underlying pathophysiology and triggers for intestinal volvulus are poorly understood, but it can lead to bowel obstruction and bowel infarction. It classically occurs in 2 locations, either at the sigmoid colon or at the cecum. If it occurs at the sigmoid colon, there are some classic imaging findings you should know about. First is obviously a dilated sigmoid, and the second is an airless rectum. This is because air cannot get beyond the volvulus and get into the rectum. It generally occurs in the elderly. The mean age of volvulus is 70, and in children it can sometimes occur secondary to a Meckel's diverticulum, just like intussusception. We've talked about bowel obstruction a few times in this module, but let's talk about it in more detail now. So a bowel obstruction is much more common in the small intestine. About 75% of bowel obstructions occur in the small intestine. They present as abdominal pain with nausea and vomiting, and the vomiting occurs because the bowel lumen is obstructed, so contents back up into the stomach and the patient vomits. The abdomen will be distended. If you ever meet patients with a bowel obstruction, they have a large distended abdomen from all the air-filled loops of bowel inside their abdomen. You can tap on their abdomen and hear echoing from all the air inside. And then finally, they can have obstipation, which is the inability to pass stool. If you ever meet a patient who has abdominal pain and says they haven't passed stool in several days or are unable to pass gas, that's a very worrisome finding. The common causes of small bowel obstruction, the more common type of bowel obstruction, are remembered by the mnemonic ABC. A is for adhesions, B is for bulge, meaning a hernia, and C is for cancer. Large bowel obstructions are commonly caused by tumors and then by adhesions and finally volvulus. You can make the diagnosis of a bowel obstruction by performing an abdominal x-ray with the patient in the upright position. This will show dilated loops of bowel and the presence of air fluid levels. If you look at this x-ray on the screen taken from a patient with a bowel obstruction, you can see many large loops of bowel filled with air. You can also see this white interface with black here. That is white fluid that is backed up behind the obstruction, and that's the interface between the fluid, which is white, and the air, which is black. That's called an air fluid level. Now let's talk about Hirschsprung's disease. This is a congenital disorder that is associated with Downs, that is a motor disease of the intestines, and children born with Hirschsprung's disease have abnormal peristalsis of the colon. Hirschsprung's disease is caused by an absence of ganglion cells in the intestines. These ganglion cells are derived embryologically from neural crest cells, and they form the nerve cells of Meissner's plexus and Auerbach's plexus.
Recall that in the muscular layer you can find Auerbach's plexus, and in the submucosal layer you can find Meissner's plexus, and these are the nerve plexuses of the intestines that cause peristalsis. So if these neural crest cells do not migrate to the intestines and form the ganglion cells, then that results in Hirschsprung's disease, and it's very high yield to know that failure to migrate of neural crest cells leads to an absence of ganglion cells, and that is the underlying cause of Hirschsprung's disease. So an absence of the normal nerve cells found in the intestines, that will lead to obstruction from a lack of peristalsis, and that's what happens in Hirschsprung's disease.
Children born with this condition will develop dilated bowel behind the obstruction, and the level of the obstruction is where there are no nerve cells to perform peristalsis. The presentation will be failure to pass meconium, which is the first stool in the newborn baby, also abdominal distension and bilious vomiting, and classically on examination of the baby there is no stool in the rectal vault, and that's because stool cannot get past the portion of the colon that lacks nerve plexuses. Sometimes children are born with less severe disease. This is less common, and they can have chronic constipation early in life. There's a classic finding on barium X-ray imaging called presence of a transition zone that is seen in babies with Hirschsprung's disease. Barium is contrast material that lights up on X-ray, and you can insert barium into the colon and take an X-ray, and what you'll see is a large dilated portion of colon that then narrows down in a cone shape, and this is called the presence of a transition zone. The dilated portion is where the ganglion cells are normal. They are proximal to the obstruction. The narrow portion is where the ganglion cells are missing, and therefore it's not performing peristalsis, and it's resulting in an obstruction that is causing a backup of material that is dilating the portion of bowel before the section where there are no ganglion cells. The diagnosis is usually made by biopsy, and it's a special type of biopsy called a rectal suction biopsy. The reason this is done to make the diagnosis of Hirschsprung's is because the rectum is always involved. Other portions of the colon are variable. It's very high yield to remember that the rectum is always involved in Hirschsprung's disease. Now, if you just do a standard biopsy of the rectal mucosa, you may only get the mucosa, but you need to see the submucosa so you can look for presence or absence of ganglion cells. So what the surgeon does is applies a little bit of suction to the mucosa and takes a deeper biopsy that includes the submucosa, and this allows the pathologist to look for presence or absence of ganglion cells. And the treatment is to surgically resect the colon and remove the portion that lacks ganglion cells. Ileus is a term you will hear very commonly on your surgical rotations. Ileus means loss of bowel peristalsis. This can lead to nausea, vomiting, constipation, or sometimes obstipation where the patient cannot pass stool. This is commonly caused by meds, especially narcotics, which slow down peristalsis, and it often occurs after administration of anesthesia. This is called a post-op ileus. And on your surgical rotations, especially as the med student, a major part of your job will be to ask the patient if they have passed gas or moved their bowels, because the surgeon wants to know whether or not the ileus from the anesthesia has resolved. Ogilvie syndrome is a syndrome that looks just like a bowel obstruction, but there is no obstructing lesion. It's called a pseudo-obstruction, and it causes a dilated colon in the absence of a lesion that is obstructing flow through the lumen. This usually occurs in hospitalized or nursing home patients who are sedentary and not mobile. They often have severe illness or recent surgery, and it's associated with use of narcotics. The way I've always thought about this is the patient is so sedentary that their bowel has also become sedentary, and that results in Ogilvie syndrome. Unfortunately, sometimes these patients are highly symptomatic and they go to the OR for exploratory laparotomy, and in the operating room you find out that there is no lesion, and in fact what they had was an Ogilvie syndrome. Irritable bowel syndrome is a functional bowel disorder, and it's called functional because it's a problem with the function, not the structure of the bowel. The intestines have an entirely normal structure. Biopsy and other imaging procedures done on the intestines will show entirely normal findings. It is purely a problem with the functioning of the bowel. Patients with IBS have recurrent abdominal pain, and the diagnostic criteria require symptoms at least 3 days per month over the last 3 months. Patients also have to have at least one of the following features: improvement in their abdominal pain with defecation, a change in the frequency of their stool, and onset associated with a change in the appearance of their stool. And IBS can cause diarrhea, constipation, or both. This is a chronic disorder. It has a poorly understood cause. It's more common in women. It has few reliably effective treatments. The treatments are often directed at symptoms. So for example, if the patient is constipated, you try to treat constipation. If they have diarrhea, you try to treat diarrhea. This is a very common disorder that you'll see many times in the primary care setting, and unfortunately we have very few effective treatments for it. Necrotizing enterocolitis is a neonatal disorder that usually occurs in the first month of life. It usually occurs in a preterm or low birth weight baby. Babies who develop this have intestinal necrosis, and this results in obstruction. It usually occurs at the terminal ileum or in the colon, and if left untreated, it can progress to perforation. The pathogenesis is unclear. It's believed that some combination of food in the GI tract plus bacteria leads to illness. One hypothesis is that the bacteria may overgrow the immature mucosal defenses of the baby. Major risk factors are prematurity and low birth weight, and these are the babies most likely to have poor mucosal defenses. So along those lines, the classic case will be a premature baby in the NICU who has abdominal distension and nausea and vomiting. There's a classic X-ray finding you should know about called pneumatosis intestinalis. This is air in the bowel wall. It is a lucent area that is parallel to the bowel. It's a subtle finding in this picture, but there is a loop of bowel here. I'm drawing a line around it with my pen, and you can see a black line right next to the intestinal wall. That is air in the bowel wall, and that is from necrosis of the mucosa, and that is a classic finding in a baby with necrotizing enterocolitis. The treatment is bowel rest, meaning you don't feed the baby, also antibiotics, and often surgery is required. Angiodysplasia is presence of an aberrant blood vessel in the GI tract, and these can occur anywhere in the GI tract, but they're common in the cecum and the right-sided colon near the area of the appendix. It's believed that they're caused by high wall stress over years of life that results in intermittent obstruction of submucosal veins. This commonly occurs in older people, so the hypothesis is that many years of intermittent compression of submucosal veins leads to the development of aberrant dilated blood vessels in the GI tract lining. Whatever their mechanism, they are a common cause of lower GI bleeding and hematochezia. Patients will present with lower GI bleeding, and on colonoscopy you will see something like the image on the bottom right side of the screen here, which is presence of an aberrant blood vessel in the wall of the GI tract that can bleed and lead to hematochezia. There's a rare inherited syndrome called hereditary hemorrhagic telangiectasia. It's also called Osler-Weber-Rendu syndrome. And in this syndrome, patients develop multiple dilated capillary beds in their GI tract that resemble the angiodysplasia we looked at on the last slide. This is an autosomal dominant vascular disease, and relatively few disorders are autosomal dominant, so whenever you see one, you should take note. Most disorders are autosomal recessive. And these patients develop telangiectasias throughout the GI tract, anywhere from the nasopharynx to the rectum. And as I said before, telangiectasias are small dilated capillary beds, but they're very similar to the angiodysplasia we saw in the last slide. And this is a picture of a man who has hereditary hemorrhagic telangiectasia, and you can see that he has telangiectasias on his lips, and these patients can get them anywhere from their nose to their lips to the rectum. Rarely, this condition leads to the formation of AVMs, which are arteriovascular malformations. These are large clumps of blood vessels that can develop in the pulmonary vasculature or in the brain. Common clinical features of hereditary hemorrhagic telangiectasia are nosebleeds, GI bleeds, and iron deficiency anemia, and this is all from the blood loss of these multiple telangiectasias throughout the GI tract. And that concludes our module on intestinal disorders.